past few years have seen the NHS put under some of the greatest pressures since its inception. This is almost inarguably a result of a decade of real terms cuts and underfunding for NHS trusts across the UK, as well as other areas such as mental health services.
Don't do it, son. We can arrange a mental health crisis meeting for you on Zoom somewhere between 6 and 12 months from now.
GP services.
Thank you for calling a local GP. You are number 3 in the queue.
A few minutes later.
Hi, thank you for contacting your local GP. How can I help?
Oh, hi there. Yes, I was just wondering, could I book an appointment to see my doctor today, please?
Today, right. Unfortunately, there's no appointments available for the next 7 years.
Okay, well, thanks anyway. And other community services such as drug rehabilitation, district nursing, among others. All of these playing a vital role in reducing the acuity of hospital admissions, or sometimes in reducing hospital admissions completely. Regular reports and even testimony from senior figures are raising concerns that NHS trusts in the UK are no longer functioning. For example, in an article in the Cambridge Independent, Adam Brooks' chief executive acknowledged that the trust was barely functioning and that unless something changed, the only alternative would be turning patients away. However, he described his words as a call to arms to tackle the challenges faced by the hospital, inferring an obligation on an already overworked and demoralised workforce, and in particular pushing up the importance of freeing up beds, and said little to acknowledge the underlying problems causing the pressure on NHS trusts even prior to COVID. Staffing was already a serious issue within NHS trusts, so much so that before the pandemic, the UK trade union Unison had set up a safe staffing forum and was due to launch its large campaign. This included a survey of staff which seemingly showed that the current staffing levels were deemed to be unsafe, and testimony from experts on the correlation between poor staffing levels and adverse, sometimes fatal, outcomes for patients. Another factor that is both a symptom of poor staffing but that also contributes to it is the issue of unpaid overtime. It appears commonplace that many nurses in the UK habitually stay behind in order to care for their patients or, through fear of failing their NMC obligations, to complete their documentation. Not only is this an example of workforce exploitation, but the fact that extra hours worked are not being recorded means that a false impression is given that wards are coping with existing resources. Having worked in another industry, the apparent normalisation of this practice among nurses came as quite a surprise to me. Now, we at corporate understand how hard you guys have worked today. Unfortunately, this job has turned out to be a lot harder than our road traffic crews were equipped for, so we're going to have to ask all of you to stay on for an extra hour, unpaid, to finish the job. Is that okay? Get f***ed. It is for this reason that I decided to do my research project on short staffing and unpaid overtime in UK nursing, and look to whether the practice is common across the UK, and if so, why, particularly in an industry that has such a high level of union recognition and activity. For the purposes of this survey, I decided to use a quantitative method in order to gain a national picture of the situation. I used an online survey website to generate a questionnaire and ran it for approximately 2 weeks. From experience, I knew that this survey would need to be kept short to encourage maximum participation, so I limited it to 9 multiple choice questions. The survey was then shared nationally across social media, primarily on Facebook but also on WhatsApp, and I targeted groups including NHS workers, nursing forums and NHS activist groups. In total, I received 186 responses. As specified when the survey was shared, all respondents were registered nurses. Of these, the vast majority were employed by the NHS, with a small percentage from the private sector. Union recognition was high among employers, with the vast majority of participants being a member. Non-union recognition is unusual and only occurs outside of the public sector or external providers. Short staffing was very common, with 98% having experienced it, and 62% estimating that over 60% of their shifts are not fully staffed. 98% of the staff had experienced being late out of their shift, with over half estimating that this accounts for over 60% of their shifts. This estimated amount of time nurses stayed behind varied, but only a small percentage said that they were out within 15 minutes. A slight majority of those asked said they would be comfortable asking their line managers to adjust their hours if late out, but only a minority said they would be willing to follow this up with their trade union. A vast majority of 92% said that they felt unpaid overtime was more normalised in nursing than in other professions. Though 186 responses would not be sufficient in order to maintain the standards of a large-scale academic study, it was more than enough to gain an insight into the desired topic. Though a small amount, it was good to receive input from colleagues in the private sector. This no doubt accounted for the small percentage that did not work in organisations that recognised trade unions, though in retrospect of the remaining private sector workers, it would have been interesting to know which trade unions they were a part of, as it may have been that some are members of sweetheart unions, which are prevalent in the private sector. Fully staffed shifts were clearly a rare occurrence among those surveyed, and this is in line with the expectations of myself and those I know in healthcare. The amount of shifts where participants were late out was clearly shocking, or at least would be to anyone who works outside healthcare. On the subject of requesting change of hours, it was encouraging to see, if only by a small margin, that a majority of participants would be willing to proactively request a change of hours, though the fact that 46% would not feel comfortable doing this is a serious concern and speaks to the normalisation of unpaid overtime in nursing. Question 8 arguably threw out one of the biggest concerns, that a majority of nurses would not be willing to approach their trade unions to escalate a request for paid hours if a manager refused. In retrospect, having seen the results of this question, my biggest regret is having an "if not, why?" question. In its absence, we can only suppose that nurses may fear victimisation were they to go over the head of their line manager, or that it might be a cultural issue. The NHS relies on an immigrant workforce, and overseas colleagues, from discussions with many of them, often come from places like India, the Philippines, Spain, Italy, and are used to much more hierarchical healthcare systems, and so may be naturally much less inclined to speak up against perceived unfairness. In this instance, have their unions failed them by not making it clear that they would be supported? The final question leaves little room for interpretation, and shows that many nurses feel that unpaid overtime is more normalised in nursing than in other professions. Though short staffing and unpaid overtime do no doubt exist in other sectors, the extent to which healthcare organisations rely upon it is something that needs to be looked at.
Poor staffing adversely affects patient safety and causes an increased workload on existing staff, which leads to increased pressure on staff, which leads to a reduction in staff retention, which leads to poor staffing. And so this shitty cycle continues. So, how do we destroy this cycle?
The first recommendation that seems apparent is that more academic research needs to be carried out on the various elements of short staffing and its correlation to unpaid overtime. Though this research project does offer some insight, there are many more correlations that could be explored, for example, the effect that short staffing has on retention, and how that, in turn, affects unpaid overtime. However, this study does allow for certain conclusions, most notably that trade unions have a role to play in improving the current situation for nurses. Though trade union membership numbers are encouraging, the fact that so few nurses would have the confidence to approach their trade union if they had an issue with unpaid overtime should be a wake-up call that we need to be doing more to make ourselves visible and empower nurses, and that all of our colleagues in healthcare have a right to fight to be paid for the work that they do. The biggest stumbling block in this would appear to be the fact that unpaid overtime is so normalised in healthcare. This is possibly down to a combination of factors, most notably the aforementioned employment of nurses from overseas, not wanting to rock the boat, particularly when they've made a life-changing decision to relocate abroad and may lack the confidence to speak up against unfair treatment, though there may be another factor at play, which is that nurses are just too nice. Many young people go straight into nursing, and, especially since the abolition of the nursing bursary under the current government, fewer mature students may be entering the profession.
and so many nurses will know nothing other than the norms experienced by their peers and will accept things like short staffing and unpaid overtime as a part of nursing. This can be seen in the fact that, despite more consistent trade union representation than in many other professions, nurse participation in trade union activity and ballots is relatively poor.
In order to counter this, trade unions have a major role to play in both reinforcing the rights that nurses have within their role, as well as the support we are able to offer. We must make it clear that the current situation is not acceptable and that those experiencing it have recourse to escalate. In our capacity as negotiators within trusts, we are able to highlight these issues without the fears that an ordinary nurse on the ground might experience, and ensure that line managers who do not share opinions about whether or not nurses should be paid for overtime are subject to retraining. This relationship with trusts also brings us to another role of a trade union, and that's the protection of staff. We've seen that unsafe staffing levels are very much normalised, but the consequences of unsafe staffing levels are very much not normalised. When things go wrong, sometimes fatally, the fact that a working area is not operating at full working capacity, but is operating at full patient capacity, is almost always not a consideration. And a form of mock incredulity is often adopted in disciplinary proceedings by trusts who would rather apathetically watch a hard-working nurse lose their qualification than risk even a whiff of adverse publicity. Trade unions have a vital role in supporting our members, ensuring they have ways of escalating unsafe shifts and ensuring that decision makers are held responsible for the effects of said decisions. And if the point is reached where trust-based decision makers have no control, for example, national budgeting, trade unions should be ensuring that the heads of trusts and chief nurses are escalating both publicly and loudly the issues to central government, telling hard-working trust employees that the whole situation will be solved if they simply work harder, then allowing an MP of the same government that has caused the current crisis to attend the trust for a PR photo shoot is, in my humble opinion, extremely distasteful and an insult to those staff on which they have relied in arguably one of the most difficult periods in the history of the NHS. Alongside this, trade unions should also focus on personally raising awareness of the current situation. We have a unique role in being both an integral part of NHS trusts, but also representing the interests of our members, so we are able to objectively raise concerns without the issues that a junior colleague may have, fearing reprisal from a line manager. We can escalate these issues not only to senior trust figures, but externally through the media, and combating government narratives about investment in the NHS. In short, the findings of this survey are not just a poor reflection on the state of UK nursing, but also on us and our obligation as trade union reps. We should be combating the kind of thinking that leads to nurses thinking that short staffing and unpaid overtime are the norm, that prevents them from coming to us when the hours they work are not paid, and when their labour is considered disposable, or when we are left short-staffed and vulnerable.
See, as one commentator put it, short staffing is a bit like drink driving. You may get away with it the majority of the time, but it never stops being dangerous.